So this lecture will focus on the peripheral nervous system. The spinal cord, of course, is part of the central nervous system, and we will talk about that at the beginning of this lecture, and then the rest of it will be about the nerves that come out of the spinal cord, which really make up the peripheral nervous system. So even though the spinal cord is part of the central nervous system, we're going to include it here in the peripheral nervous system just because it makes more sense anatomically. So we'll start with the spinal cord gross anatomy, just looking at the spinal cord as a whole and kind of breaking it up into sections. And what you'll see is that basically we're breaking it up into sections just like we broke up the vertebrae. So we had cervical vertebrae, thoracic vertebrae, lumbar vertebrae, and then the sacrum and coccyx. Here we're going to have 4 sections to the spinal cord: cervical, thoracic, lumbar, and sacral. So those should be easy terms to remember since you've already learned them. One big difference is there were only 7 vertebrae in the cervical spine, but there are 8 nerves that come out of the cervical area. And if you kind of blow up the picture, you'll see why that is. So C1, which is the nerve that comes out between the first vertebrae and the occiput of the skull, that actually comes out above the C1 vertebrae. So then each subsequent nerve that comes out of the spinal cord is going to carry the name of the vertebrae below it. So the first one is C1, and that comes out above the vertebrae C1, and then the nerve C2 comes out above the vertebrae C2, and so on. So when you get to C7, that nerve comes out above the C7 vertebrae. So then what do you call the nerve that comes out below the C7 vertebrae? And that's where C8 comes in. So they name that one C8, and then they start naming the thoracic nerves after the vertebrae just above it. So T1 will come out just below the vertebrae T1, and T2 will come out just above. So you would have T1 there, and you would have T2 there, and you would have T3 there. And so the nerve is going to come out just below each of the vertebrae that it's named for. And there are 12 thoracic vertebrae, and there are 12 thoracic nerves. There are 5 lumbar vertebrae, and there are 5 lumbar nerves. So it's only the cervical that's really different from the vertebrae that you have already learned. Okay, as you move down, see if this picture probably does a better job. So if you're looking, so here are the vertebrae out front, right? Those are the vertebral bodies. These are the spinous processes in the back here. And right here is the spinal cord going down. And so the color codes cervical, thoracic, and lumbar, and then sacral. And notice that the spinal cord itself, the kind of the spinal cord proper, really ends right here at about L1. And so that part of the spinal cord where it kind of comes to a point, it kind of looks like a cone down there, so that we call that the conus medullaris, because that's the area that looks like a cone where the spinal cord kind of comes to a point. And after that point, you'll notice there's still nerves coming off of the spinal cord, but they kind of look like they come off in long strings or even hairs, some people have thought. And so we call that the cauda equina, which means horse's tail, because it kind of looks like, a bunch of hair off of a horse's tail. And this is important if you remember when we talked about potential injury to the spinal cord, especially if we're introducing something like a needle into the spinal space to collect cerebrospinal fluid. We said that we wanted to go in between L2 and L3 or L3 and L4, and that's because if we go any higher than that, if we went, let's say, between L1 and T12 or T11 and T12, and we put that needle, we might actually injure the spinal cord. But if we enter that needle through L2 or L3, there is no real spinal cord anymore. It's just a bunch of kind of loosely flowing nerves that could easily move out of the way of the needle and are much less likely to be punctured or injured by the needle. So understanding that the conus medullaris ends at L1 and the cauda equina will begin right where the cona medullaris ends. So make sure you know those two terms as well as the different levels of cervical, thoracic, lumbar, and sacral. Okay, we can also look at cross-sectional anatomy of the spinal cord. So if we take a cross-section, remember that's like a horizontal cut through the spinal cord. This is what you would see. You can see that in general, whether you're in the cervical, the thoracic, or the lumbar, so this picture is showing you cervical and thoracic and lumbar, that you have the same kind of basic structure where you have white matter filling out the outside, and in the center you have some form of gray matter, and that gray matter looks like a butterfly, more or less. Now you can see that it changes a little bit as it goes, but the same general structure is there. So white matter on the outside, gray matter on the inside. There's also a couple of kind of slits that you can see, or almost like I don't know what you would call them, ridges and valleys that you can see. So if you're looking, let's just look at the cervical one for a minute. You can see that there is this kind of scalloped appearance to the front. To the posterior aspect. So this would be anterior here. This would be posterior here. And so you're seeing that there's a couple of sulci, which are like deep ridges that go down into the body of the spinal cord. And the center one we give a name. We call that the posterior median sulcus. So we talked a little bit about gyri and sulci in the brain lecture that we had in lab the other day. So this is kind of a smaller version of a sulcus. And because it occurs in the posterior part of the cord, we call it the posterior sulcus. But because there are multiple sulci back there, we call the one directly in the middle the posterior median sulcus. So that's where the name comes from. Well, there's also an anterior median fissure, and we call it a fissure just because it's not a sulcus where it just kind of does an indentation. It's an actual fissure. It's an actual opening there, and it's wider than the sulcus is, and so we call it a fissure. But again, it's anterior and it's in the middle, so it's anterior median and it's a fissure. So those are two other kind of anatomical structures you can see grossly on the cross-section of the spinal cord, along with the white matter and the gray matter that we discussed. Then there are some things that are coming out of the spinal cord, and this gets us into the peripheral nervous system, and I'll just mention it in this picture, and we're going to go into a lot more detail when we get to the peripheral nervous system side halfway through this lecture. But notice that coming out of the spinal cord, you have nerves, and those nerves are the beginning of the peripheral nervous system. Well, you have nerves that come out of the back, and so those are going to be dorsal, right? Remember, dorsal means back. And we call that root because it's the beginning of all of the nerves that come out the backside of the spinal cord. So that's the dorsal root. And that's going to be white matter. That's going to be axons coming from the spinal cord. Well, they are going to synapse here at the dorsal root ganglion. And you remember we talked about ganglion being a collection of gray matter cell bodies in the peripheral nervous system. And then from the dorsal root ganglion, they will travel out to the body. So just like we have a dorsal root, we also have a ventral root. And so the dorsal root and the ventral root will come together and form what's called the spinal nerve. So this might be, for example, spinal nerve C3, which is what that's saying there. All right, so we will, I forgot to mention the central canal right down. So the spinal cord itself is surrounded, if we just kind of looked we're going to see there's like covering layers to this spinal cord, the mater that we talked about in the brain, the dura, the pita, and the arachnoid. They're here as well in the spinal cord, and the spinal cord is kind of floating in a little bit of cerebral spinal fluid, just like the brain is. So that's why it's like part of the same structure as the brain. It's all part of the central nervous system. So the spinal cord itself is floating in cerebral spinal fluid, just like the brain is. But there's also a central canal. You can see a hole there, and you can see a hole there, that itself is also flowing with cerebral spinal fluid. So right down the center of the spinal cord, there's a long canal that's also filled with cerebral spinal fluid. And all of that just kind of helps to absorb shock and absorb force and help protect the spinal cord itself by being surrounded both on the outside and right down the center with cerebral spinal fluid. So that's called the central canal. All right, so just like we talked about with the brain, here in the spinal cord, there are three maters as well, the dura, the arachnoid, and the pia mater. No different really than what you learned in the brain already. Just remember that because the spinal cord is part of the central nervous system, that same structure of the maters continues from the brain down into the spinal cord. Okay, I already mentioned the dorsal root ganglion on the other picture. Now we're going to add a little bit of information here. Unfortunately, this picture is the opposite of the last picture. So the previous picture had posterior up top and anterior on the bottom, but this one is going to have anterior up here and posterior here, or you might say, excuse me, remember ventral is another word for anterior, and dorsal is another name for posterior. So if we start with the dorsal root, because that's kind of where we started last time, remember that's coming out the back side, and so you're getting all these nerves that are coming, and they're going to form that dorsal root, and then you're going to get that ganglion, that cell body, that collection of cell bodies or gray matter in the peripheral nervous system, and then they're going to form the spinal nerve, as we mentioned. Well, the dorsal root ganglion specifically carries sensory information. So it is receiving from the periphery, from your arms and legs and chest and abdomen, it's receiving sensory information, sending it to the spinal cord, and then up to the brain. So you can kind of think of information coming in this way. The ventral root ganglion on the anterior side, so here are the ventral rootlets coming, and there's that ventral not ganglion, but the ventral root there. That is, I shouldn't have this word ganglion here. I'm sorry about that. It should just say that. It should say dorsal root ganglion, then it should just say ventral root. So think of the ventral root as information coming out the other way. So the cell bodies begin here in the anterior horns, or the ventral horns, in the gray matter of the spinal cord, and they are going to send their signals out in this direction to tell the muscles of your periphery when to contract. So the muscles of your arms and legs and hands and chest and all that. So ventral root is sending efferent information, motor commands, and the dorsal root is receiving sensory or afferent information. So remember, dorsal for afferent and ventral for efferent. All right, so we're going to keep adding some information. So now we're getting a top-down look at what the spinal cord looks like in its, actual environment, and you can see it surrounded by the vertebral body here, and here's the spinous process here, and the pedicles and everything else. You can also see the different maters that we talked about that are kind of surrounding it. You can see that there's some empty space in there where the cerebral spinal fluid would be floating around. The central canal where the fluid would be flowing through. You can see there's a cushion of fat around it. All of this to protect the spinal cord, which is very delicate and very important. But you can see that you also need these openings in between the vertebral body and the transverse processes in order for the nerves to exit the spinal cord as you move down the spine. And so, again, this is nothing new. We've been talking about these terms like dorsal root and ventral root. We're just going to add some new terms to that, okay? So the dorsal root would come out through here. There's the dorsal root ganglia. The ventral root would come out anteriorly, and they're going to come together to form the spinal nerve. So we would call kind of this whole thing here the spinal nerve. Now, as the information kind of comes out from the spinal nerve, you get some information that's going to go to the autonomic nervous system, and we're going to talk about that separately. And that's going to come out in this direction, and you're going to receive information back in through that area. You can see on the other side of the picture, here's the autonomic ganglion. And then you're also going to get from the somatic portion of the peripheral nervous system, you're going to have two rami that come off of that spinal nerve. One is ventral, one is dorsal, and it's just exactly what it sounds like. One is giving and receiving information from the back of the body, and one is giving and receiving information from the front of the body, ventral and dorsal rami, you can see there. And so we'll see this again as we get into some pictures coming up. We'll be able to see these same structures kind of blown up and can kind of see it a little bit bigger. I'll just say that sometimes, just clinically speaking, sometimes we will introduce a needle in between two spinous processes, and we are trying to get right into that space in between the spinal cord and the dura and the fat. The mater and the fat. And we're trying to either remove fluid, like we talked about with the lumbar puncture, or we're trying to insert something. We're trying to inject something like a steroid, for example, that we might be able to get into the space. Usually for the steroid, we would come more and try to get the steroid in that space, because maybe this root is inflamed and swollen, or maybe the disc is kind of pushing out there. So we'll try to get our needle right in that space, what's called the epidural space, the space just inside the dura, and we will try to inject a steroid to reduce inflammation there and help with pain. I just thought this picture here was interesting to see what it looks like in real life. You can see all of these spinal nerves coming off of the spinal cord in real life and see what it looks like. Excuse me. Okay, so we're going to keep talking about cross-sectional anatomy of the spinal cord, but we're going to specifically focus on the gray matter, the darker colored tissue. So in the picture that you see here, you've got kind of a butterfly shape gray matter, right? And we're gonna divide that gray matter up into three portions: an anterior portion, a posterior portion, and a lateral portion. And we're gonna call them all horns because they kind of stick out. They're a little bit pointy, like horns. And the anterior part is going to be somatic motor. The posterior part is going to be sensory, both somatic and visceral. And notice we have here somatic motor, so we're missing visceral motor, right? Visceral motor is going to be on the lateral horns. So if we kind of come back out here and take a look, we'll talk about the anterior horn, right? That's basically this section of the gray matter, and that's going to be the somatic motor. And then the posterior horn, that's going to be basically this area, and that's going to give you sensation, both somatic and visceral. And then the lateral horn is kind of the part that's in between, and that's where your involuntary or visceral motor cell bodies are that control the motor commands that tell your glands when to secrete, for example, or tell your abdomen or your intestines when to contract and mix food and things like that. So, and your heart when to beat. So all of that's going to be done in the lateral horn. That's the the autonomic or the visceral component. Okay, so remember, anterior is somatic motor, posterior is all sensation, and lateral is visceral motor. So here's another look, kind of a drawing just to help us see a little bit better what we were talking about. Another way to think about it is that the somatic portions, meaning the voluntary muscle parts, occur on the anterior-most and the posterior-most parts of the gray matter. So you can see somatic is back here posterior, and somatic is up here anterior, and the visceral kind of make up the area in between, with the visceral sensory going along with the somatic sensory, and the visceral motor kind of being off by itself. All right, so you can think of signals from the body, let's say from your skin. Let's say you touch something painful, you touch a pin and it pricks you. That information is going to come from the nerve in your finger and eventually make its way to the dorsal root ganglia, and it will synapse here in the gray matter in the ganglia, and then another nerve will come out from the gray matter and will synapse in the gray matter here in the spinal cord, so that your spinal cord gets the signal from the periphery that something painful has happened. And then your spinal cord is going to send that information up to the brain, and when it hits your cerebral cortex, that's when you're going to become consciously aware that you've actually touched something sharp. So until that signal makes it up to your brain, you're not actually consciously aware of any pain. And what may happen is it may send a signal up to your brain so that you become consciously aware, but it may also cause a reflex, which will then go to the ventral root, and ventral root, remember, does motor, and then will send a signal eventually down that same pathway, but going anteriorly, and it will tell your hand to contract, for example, or your finger to contract, to move it away from that tack or that sharp thing that you touched. And only after the reflex actually is your brain consciously aware that you've touched anything sharp at all. We do call, I just wanted to make we have the central canal there, and we have gray matter surrounding the central canal. The part of the gray matter that's in front of or anterior to the canal we call the anterior gray commissure, and the gray matter posterior to that is the posterior gray commissure. So we do have names for that as well. All right, so in addition to kind of organizing motor and sensory in the gray matter, as we've talked about, there's also more organization. We're going to find that the spinal cord is highly organized, and that everything runs in very specific areas in the spinal cord. Every part of the body, every function, every type of sensation is going to have its own space in the spinal cord, and it's going to run together with other fibers that carry the same information, so that when it arrives in the brain will be able to tell what type of sensation, where it came from exactly. This organization is very helpful. So let's talk about some of the organization in the white matter. That's the area kind of on the outside of the cord. So we're going to have, just like we had 3 horns in the gray matter, we're going to have 3 columns that we're going to learn in the white matter, and they're pretty much the same. They're posterior, anterior, and lateral, just like we learned in the gray matter. And just like we talked about with the gray matter, that there was kind of an organization for sensory versus motor, we're going to find organization in the white matter as well, with ascending tracts carrying sensory information up to the brain, and descending tracts carrying motor commands down from the brain to the spinal cord, and then out from the spinal cord to the peripheral. So let's look at some of these different tracts that we talked about. So we'll start with some sensory tracts, and we're going to notice that there's 3 different types of arrangement of sensory tracts, and we'll go through each of them here briefly. So there's an organization for the type of sensation. So the things that we feel in our environment are not all the same. For example, whether you know something is cold or hot is not the same kind of sensation as if something is soft or rough. Those are different types of sensation. They require different types of receptors, and therefore they are carried in different parts of the spinal cord up to the brain. So pain sensation, for example, is separate from vibration, is separate from temperature, and these are all going to have their own tracks within the spinal cord, their own levels of organization. So that's kind of level one of organization is what type of sensation is it, and the same type will go together in the same portion of the spinal cord. So, for example, if we kind of blow this picture up, you can see sensory fibers that are carrying touch, pressure. Proprioception is position sense. It comes from your joints. Are your fingers flexed or extended? Your brain knows that from proprioceptors. And vibration. So those four types of sensory fibers all are carried up to the brain in the posterior part, the posterior columns of the spinal cord. Sensory information that carries pain and temperature, however, are in the lateral columns. And sensory fibers that do crude touch, just to know, hey, is something touching me, or am I touching something that's solid, or something, or am I touching nothing at all? These are kind of crude touch. Those are going to be carried in the anterior columns. So you see that different types of sensation are grouped together in particular areas of the spinal cord. Okay, level 2 of organization is going to be the idea that sensation is carried within those columns from medial to lateral. So the most medial side of those columns will carry the lower limb, and the most lateral sides of those columns will carry information from the upper limb. So you can see here in this picture, so if we're looking at the posterior columns, which are here on both sides, if we could kind of look in more detail, we would see that not only is it carrying, only fine touch, pressure, proprioception, and vibration, but it's also carrying it in a very organized fashion so that all of the fine touch, pressure, proprioception, and vibration from the lower limb are all carried on this part of the spinal cord all the way up to the brain. Whereas those from the upper limb are going to be more out here laterally, and they're going to stay in that column all the way up to the brain. So that's level 2 of organization, kind of a medial to lateral, lower to upper limb type of organization. The third type of kind of organization is that sensory tracts will be arranged according to their site of origin. So, for example, even within, so we're talking about lower to upper, medial to lateral, that was kind of level 2. But there's an even deeper level within, let's say, the upper limb. You're going to have an organization where the sensation from the tip of your index finger always falls on the same area of the spinal cord, and it gets carried up that same track every time, and is going to land on the brain in a particular spot that corresponds with that tract. And that's how your brain is going to know that that sensation came from that particular location. We call that somatotopic arrangement, and we're going to see a picture here in a minute of how that's important on the brain. Okay, so we can talk about kind of levels of neurons, or we call them orders of neurons. So the very first neuron, let's say we're talking about sensation. In this case, we're going to talk about sensory neurons. The very first neuron that comes from the periphery, let's say it's that one we were talking about in your index finger. And it comes from your index finger, and it goes all the way up your arm, and it's going to synapse in that dorsal root ganglion, right? So that first nerve, that's called the first order nerve. Okay, and then that's going to go up the spinal cord, and it's going to synapse somewhere else. It's going to synapse perhaps in the brainstem, and we're going to call that then the second order nerve. And then from the brainstem, it's going to go up to the cerebrum, to the higher parts of your brain, and we would call that maybe the third order neuron. Sometimes there are fourth order neurons, and we just kind of keep building depending on how many synapses and how many neurons there are between the original sensation and the brain. Okay, but the point is, as we were talking about in the previous slide, is that let's say a pin is touched to your index finger, that's going to travel along the same part of the brainstem, and it's eventually going to cross, right? Just like we learned in the brain that the opposite side of the brain controls your body. So the right side of your body is controlled by the left side of your brain, and vice versa. And it's the same thing with sensation. When information goes back up to the brain, you're going to receive information from the right side of your body to the left side of your brain. And it's going to land in the same area every time, and that's how your brain is going to know when this kind of series of neurons lands right in that area. That corresponds with my index finger. So I know that the pain that I felt, the prick that I felt, came from my index finger. That's why this level of organization is so important. And your brain is going to know that this was pain and not temperature, or this was, pain and not just crude touch. So it's going to know exactly what type of pain and where that pain came from because of the organization in the spinal cord. But notice this interesting picture at top where you've got a brain, and we're looking at the primary somatosensory cortex. So that's going to be just posterior to that central gyrus, right? Or that central sulcus. So this will be where we'll find this primary somatosensory cortex. And so all of the sensation from our body, not the organs, but from the rest of our body, the somatic part, is going to land somewhere on this gyrus of the brain, of the cerebral cortex. And it's not, every part of the body is not equal in this sense. So for example, look at how big the thumb and the index finger are. There was more space devoted on your somatosensory cortex to the index finger than there is to your entire upper arm. And that's kind of what this picture is showing you, is it's exaggerating the areas that have more sensory fibers, that have more of the brain dedicated to receiving sensory information. This is why your index finger, for example, and your thumb, they're very sensitive to touch. And this is why we use our finger and thumb to pick up very small items, or to do very sensitive things like writing, where we have to have very fine sensation on the one hand, and we have to have very fine motor function on the other hand. So in this picture, we're looking at the sensory part. Notice some other areas that have a large area compared to their body size. Lips, for example. Your lips are very sensitive. They have a lot of sensory receptors, and the brain devotes quite a bit of real estate to receiving that information. And so your lips on this picture look large. We call this funny looking picture, we call it a homunculus. And this is the sensory homunculus. So we'll see later a motor homunculus, which has a few differences. But it's a representation of what parts of the body have more sensory receptors. Of course, the genitalia is also very sensitive, and so it receives a rather large part. Notice the foot has a larger part of the brain than the whole, shin, even though the foot anatomically is smaller. Or your chest, for example, or your abdomen. Very small section of the brain is devoted to the abdomen compared to things like your hand, your foot, your genitalia, or your lips, or your face. So we call that the sensory homunculus. All right, well, there is also a motor homunculus, and I'll just show you that picture real quick. So this would be on the primary motor cortex, just anterior to the primary somatosensory cortex that we learned. Notice how large the tongue is, because there is a lot of brain power devoted to moving the tongue for things like speech, for chewing, for swallowing. Your tongue is important for all of that. Notice how large just the face in general is, how large the hand is compared to something like your shin or your abdomen. Excuse me. Because those parts of the body require a lot more signals, a lot more information being sent from the brain to the muscles in those areas in order to make those muscles move. Those muscles are very fine muscles. A lot of them are fast twitch. They're devoted to doing fine motor skills, or the muscles of facial expression, how we show surprise, how we show disgust, how we show happiness, how we show sadness. This is all very complicated and requires a large portion of the brain in order to make that happen. Okay, but in addition to the homunculus, which you can see there, we can also separate motor tracts. So we were talking about sensory tracts, right, coming up the posterior column, the lateral column, the anterior column. Well, we're also going to have motor tracts going down the spinal cord, and they're going to also follow an organized pathway down. But I wanted to talk about generally how we look at motor information that's coming from the brain to the spinal cord and out to the periphery. So we talk generally about two types of motor neurons. We talk about those that are in the brain itself, and we're going to call the ones in the brain because that's where the signal originates, right? If you want to throw a ball, that signal originates in your brain, and then your brain has to send a signal down to the spinal cord to make all of those muscles move in a coordinated fashion so that you can throw a ball. So the signal starts up in the brain, and so we call those neurons upper motor neurons, the ones that start up on the cerebral cortex. So they're going to go from the cerebrum to the brainstem, or they may go all the way down to the spinal cord. Now, what's interesting about these neurons is they can both be excitatory, meaning they're going to cause muscles to contract, or they may be inhibitory, meaning they're going to inhibit some muscles to contract, because you're talking about fine-tuning a movement. And so while throwing a ball, I may want some of the muscles of my hand and wrist and arm contracting, and so that would be the excitatory signals that I'm sending. But I want other parts, other muscles to be relaxing, right? To not fight the contracted muscles. So I actually have to inhibit contraction in those muscles. And so these upper motor neurons are doing both. They're both excitatory and they're inhibitory. And so damage to them, if you have damage to excitatory neurons, that means you're not going to be able to contract, right? So you're going to have muscles that are very loose, very flaccid, very floppy, because you can't excite them to contract. However, if I lose the ability to inhibit muscles, that means muscles will contract when I don't want them to contract. And so that's why when you damage upper motor neurons, like if you have brain damage, let's say from a stroke or a tumor, you get increased tone. You get muscles that are contracting even when you don't want them to be contracting. And so when you check the tone of an arm or a leg or a wrist, you'll find that you have increased tone because you've lost not only the excitatory, but you've lost the inhibitory. And you'll also find that your reflexes are hyperactive for the same reason. You've lost the inhibitory neurons that kind of relax those reflexes and make them less severe. Okay, on the other hand, we have lower motor neurons. Those are the motor neurons that come from the brainstem or spinal cord, and then they go out to the peripheral muscles. And these are excitatory only. So once the signal reaches the spinal cord, or the brainstem in some instances, now it's all or nothing contraction. So whatever signals make it there, they're going to go out and cause muscles to contract. So if you have a spinal cord injury, let's say you were in a car accident and you broke, your L2 vertebral body and you severed the spinal cord there. That means everything below L2 is not going to receive any excitatory signals because all of those signals are excitatory. And so you're going to then have decreased tone, right? Because you don't have any excitatory signals being sent to those muscles. So those muscles cannot contract. So they're going to be floppy and flaccid. And your reflexes will also be hypoactive, meaning they won't work at all in most circumstances because you won't be able to get any excitatory signals sent back to the muscles to contract. Okay, so upper motor neurons coming from the brain, lower motor neurons coming from the brainstem or spinal cord. Loss of upper motor neurons causes increased tone and increased reflexes. Loss of lower motor neurons leads to reduced tone, we would say plasticity, and reduced reflexes or even absent reflexes. That's really important, by the way, if you're trying to figure out someone says they can't walk, they have weakness in their legs. You want to know, is the problem in the brain or is the problem in the spinal cord? So if you check the reflexes in the patella, for example, the patellar tendon, and they have hyperreflexia, their leg kicks out super fast, then you know the problem's up in the brain. Something like Parkinson's maybe, or Huntington's, or so many other brain diseases. But if you check their reflexes and it's flaccid and they get no reflex, now you're more worried about a problem in the spinal cord. So that's how that information is used clinically. Okay, so we've looked here already at this spinal cord anatomy, right? So make sure you kind of have that in mind. But we're going to now move out from the spinal cord into these various spinal nerves that we were talking about, right? So there's going to be 8 spinal nerves from the cervical spine coming out on each side. So 8 right-sided spinal nerves and 8 left-sided spinal nerves. And then we're going to have 12 thoracic, 5 lumbar, and 5 sacral. All right, so I've already mentioned some of this. So some of this will be review, but hopefully it'll help you understand it a little bit better, seeing it more up close and in more detail. So we're looking at spinal nerve distribution. We're looking at how does information come into spinal nerves and how does information go out from spinal nerves. So the axons from the ventral horn, we already talked about. So we're going to say that this, in this picture, this is anterior, this is posterior. And you know that because you've got the fissure is anterior, right? And the sulcus is posterior. So if we look at axons that are coming from the anterior portion, remember we have anterior horn cells, and they're going to, or ventral horn cells, and they're going to be motor neurons that are going to go out to the muscles and tell the muscles to contract. If you remember, we talked about that a little while ago. And then right behind that, you have a section in the anterior part of the lateral horn that's going to go out to visceral muscles, right? Maybe stomach muscles, or maybe glands, some type of organ. And so that's going to be all kind of in the front part of the gray matter, and it's going to travel then through the ventral root. So axons from the ventral horn travel through the ventral root. Okay, and that's what we call this part of the spinal nerve. So the ventral root and the ventral root and the dorsal root are going to come together to form the spinal nerve. So we're just kind of breaking down the spinal nerve into its components. So ventral is going to be the motor component. Somatic fibers that come from ventral root are going to eventually come to the spinal nerve, and then they're going to split into 2 areas. So they're either going to go down the dorsal ramus here, posteriorly, and then they will signal muscles on the backside of your body to contract, or they will travel along the ventral ramus, which is here, which just wraps around to the front of your body and tells the muscles on the anterior part of your body to contract. Okay, so the motor signal started in the gray matter and the anterior horn, and then followed through the ventral root, and then the ones that are for posterior muscles went through the dorsal ramus, and the one for anterior muscles went through the ventral ramus. Now the visceral fibers, the ones that are going to organs, they're not going to go through the dorsal or the ventral ramus. They have their own pathway, and that's called the rami communicantes. So we're talking about different rami, right? We have dorsal ramus and ventral ramus for the somatic motor commands. The visceral motor commands have another ramus, but we give it a different name. It's called the rami communicantes. And I'm not going to make you learn the white and the gray ramus there. Just know the rami communicantes are going to carry visceral fibers, and they will synapse. Some of them will synapse in the sympathetic ganglion if they're sympathetic signals, and some will follow down to the sympathetic nerve, and then that will go out to the organ. So we're just separating somatic motor commands and visceral motor commands, and they kind of leave the spinal cord at different parts. Okay, now we're going to switch to sensory. So remember, sensory is going to go to the dorsal aspect of the spinal cord through that dorsal root. And so it's going to come from the periphery, from the outside of the body, from your arms and legs and your skin and your muscles and your joints, and it's going to send information back to the spinal cord. And we're going to separate this as well into somatic information and visceral information. So let's start with the somatic information. So information that comes from proprioceptors on your back, for example, or on the back side of your body, they're going to also go through the dorsal ramus and synapse in the dorsal root ganglion, and then from there they'll go back to the spinal cord. Sensory information that comes from the anterior part of your body is going to come through the ventral ramus, and it will also synapse on the dorsal root ganglion, and then from there follow the dorsal root back to the spinal cord. Sensory information that's coming from your organs is going to do the same thing that the motor information did, just in the opposite direction. So it's going to follow the rami communicantes and eventually synapse again at the dorsal root ganglion, and then from there go to the spinal cord. So sensation is highly organized in the body because of these spinal nerves and the way that they're organized. We can tell exactly from where your pain is or where your numbness is. We can trace that back and find exactly where in the spinal cord or what spinal nerve is being damaged. And so we have maps of the body, like you can see here, that we call dermatomes. So the dermatomes are strips of areas on our body that correspond to a particular spinal nerve. And so, for example, if we blow it up, we know that your belly button is at about T9 or T10. And so if I've got pain around the belly button, then I know the problem is going to be at the spinal root of T9 or T10. Let's say the nipple, for example, is somewhere around T4. So if I'm having an issue there, I know that the problem is in T4. If you're having pain in the groin, for example, then the problem will be at L1, and so on and so forth. So you see how that kind of the map of the dermatomes helps us determine if you're having sensory symptoms. We can trace those symptoms back to their source by looking at this map of the dermatomes. So a few that I want you to learn because I think they're really helpful, excuse me, just to give you a reference. And if you can keep these in reference, then you'll be able to kind of guess where sensory problems in between these reference points might be coming from. So for example, the nipple in a male is going to be T4, the navel or umbilicus will be T10, the forearm is going to be C5 through C8. The thigh is going to be L1 through L4, so L1's the groin, then L1 and 2, L3, L4, all the way down And L5 would be like your shin, for example. S1 and S2 are going to kind of come down the posterior aspect of the leg. And then the anus, which is S5, which is this area right here, that's important because we test for that sometimes if someone has a spinal cord injury or is complaining of numbness or tingling or weakness in the lower extremities, and we want to know how far is the damage. We will kind of take a gloved finger and just kind of rub that area near the anus and see if the anal sphincter contracts. It's a reflex, so if you touch that area, the sphincter will contract. Well, if you've lost sensation to that area, your sphincter will not contract, and you will rub that area and notice there's no contraction. If that happens, then you know that S5 is not receiving any sensory information, and so then that tells you that there's at least a problem at S5, and that it's not just something that the patient is feeling, but it's something that there's a true spinal injury there. So we do that often to test for spinal injury. Okay, I wanted to talk just a little bit about different plexuses that we have in the peripheral nervous system. The main ones that we'll talk about are the cervical plexus, the brachial plexus, and the lumbosacral plexus. A plexus is just kind of a network of blood vessels or a network of nerves where a bunch of nerves kind of get bundled together. It can also be where a bunch of blood vessels are kind of bundled together. So we'll talk about some nerve plexuses. The cervical plexus, if you kind of blow this up, is this. You can see how right in this area there's a bunch of nerves. They almost look like they're net. There's a net of nerves there. So that's the cervical plexus, and that innervates like muscles and sensation in the neck, which is really important for functions like swallowing and even breathing to an extent. The brachial plexus, which you may remember from the surface area lecture that I gave, not surface area, surface anatomy lecture that I gave. We talked about the brachial plexus was located in the posterior triangle of the neck, and so you can see the brachial plexus kind of begins here and comes out to the shoulder. You see how it's another kind of network of nerves, all kind of attached and running into each other. And then lastly, we have that lumbosacral plexus kind of beginning from here down, and you can see again that kind of network of nerves. So we'll take a look at each of these individually, and you will have to start learning now some of the names of these individual peripheral nerves. All right, so if we look at the cervical plexus, that's the one that comes up to the neck that I had mentioned. There's a lot of them that are there, and those of you going on to medical school will have to learn more of them, but there's just a couple I wanted to point out that I'd like you to learn for this course. One is the phrenic nerve, and I already mentioned in a previous lecture that the phrenic nerve innervates the diaphragm, and so that's the one that really helps you breathe. The diaphragm is the primary respiratory muscle. So if you damage the phrenic nerve in surgery or in a car accident or a knife or a bullet or something like that, you may have trouble breathing. Now, if you just injure one side, you may still be able to get some breathing done through the other phrenic nerve, but if you damage both phrenic nerves, then you would stop breathing and you would die. So I do want you to know the phrenic nerve, that it innervates the diaphragm, and then I want you to learn the ansa cervicalis, which innervates the external laryngeal muscles. Those are the ones kind of in the front of your neck, and if we blow this up here, we'll be able to see. So you can see the phrenic nerve comes down off the plexus, and it's going to eventually go all the way down to the diaphragm. The ansa cervicalis is kind of a loop of a nerve that then sends off multiple axons to different parts of these anterior muscles, and these are helpful for swallowing. These are helpful for breathing sometimes, especially if you're doing accessory breathing. and so that's an important nerve as well. So just keep in mind those two nerves from the cervical plexus. Okay, as we get down to the brachial plexus, we're going to take a look at the organization of the brachial plexus for just a minute. So generally speaking, we're going to see that the brachial plexus has 3 trunks, 2 divisions, and 3 cords. And it's really those cords that we're going to be most focused on, because those cords will then turn into nerves that you're going to have to learn the names of and learn the locations of. So 3 trunks, 2 divisions, and 3 cords. So if we take a look back here, we can see that we have 3 trunks, the superior, the middle, and the inferior trunk. And those are coming off of cervical spinal nerves C5 through T1. So C5 and C6 come together to make the superior trunk. The middle trunk comes from C7, and then the inferior trunk is formed from C8 and T1. Now, as those nerves kind of move along down the line, they're going to reassemble themselves into the 3 cords. We're going to not worry too much about the anterior and the posterior divisions. We'll kind of just focus on the cords. So you can see how those nerves come together, and they're going to form a lateral cord here, a posterior cord here, and a medial cord here. And it's from those 3 cords that we get our peripheral nerves that we'll discuss. So, for example, the ulnar nerve and at least part of what will be the median nerve are going to come off that medial cord. The radial nerve and another nerve that you guys don't really have to learn is going to come off of that posterior cord. And then the musculocutaneous nerve and part of the median nerve are going to come off of this lateral cord. And so that's kind of the picture version, and you can kind of see there's the written version if you like it better that way. So if we follow the signals, the nerves that are coming out of the spine and then eventually making their way down, we're going to look at, because we're looking at the brachial plexus, these are all nerves that innervate the shoulder and the arm. So we're going to kind of follow where the signal comes out of the spinal cord and where it ends up innervating in the shoulder or arm. So if we look at the axillary nerve, remember the axilla is your armpit, right? So that's going to give you a general idea of what region of the body it's going to innervate. That's going to originate from C5 and C6 coming out of the spinal cord, and it's going to, maybe not surprisingly, if you think of the muscles around the axilla, it's going to innervate the deltoid, teres minor, so that's going to be for motor. Whenever you see a muscle on these lists, that's going to be motor. It's going to cause those muscles to contract. And then it's going to give us sensory information from the skin of the shoulder. So you're going to want to make sure for each of these peripheral nerves, there's not a lot of them that you have to learn, but for each of them, you want to know where they came from, you want to know where they go, but then you're going to have to say, okay, what muscles do they innervate and what areas of skin do they receive information from? So you're going to have to learn both motor and sensory function for that nerve. Okay, if you come down, I'm not going to make you learn this one. So if you come down to the radial nerve, that's going to be C5 through T1. And you're going to see that that does a lot of the extensor muscles of the arm and forearm. And so there's a lot of examples there. So the extensor muscles, remember, would be of the upper arm would be like triceps brachii. And then if you come down to the forearm, extensor carpi radialis, extensor carpi ulnaris, brachioradialis, and some other muscles. So just think extensor muscles of the arm and forearm. And then it also gives you sensory from the skin over the posterior lateral surface of the upper arm. You don't have to learn the branches of it. I just want you to know extensor muscles and posterior lateral surface of the limb sensation. Okay, musculocutaneous nerve comes from C5 to C7, and that's going to give you a lot of the flexor muscles of the arm. So biceps brachialis, brachialis, coracobrachialis. But it's also going to give you sensory information from the lateral surface of the forearm through one of its branches. So again, know what the motor function is and the sensory. Okay, the median nerve is really important because it has extensive innervation in the forearm and hand. So it's going to give you flexor muscles in the forearm, and you can see some examples there, as well as even in the fingers. And then it's going to give you sensory information from the skin on the anterior lateral surface of the hand. And we'll see a picture of that here in a minute. And then lastly is the ulnar nerve that comes from the brachial plexus. And you can see that starts from C8 and T1. And that's going to give motor commands to flexor carpi ulnaris and part of flexor digitorum profundus, adductor pollicis, and some digital muscles that I didn't make you learn. But then you're going to get sensory information from the medial surface of the hand. So let's take a look here at where these nerves are. So remember, you always want to ask, am I looking anterior or posterior? And where is the nerve going to be both anteriorly and posteriorly? So let's start with, let's see if we can find the axillary nerve. Maybe it's not on this picture. Let's see. Maybe it's on the posterior. Yeah. Okay, so the axillary nerve, remember, is going to innervate teres minor and the deltoid muscle, and it's going to give you sensation to the shoulder. So if you understand the function, it should help you locate it on a model or on a picture, right? So it should be in the area of deltoid and the shoulder. So if we look here on the picture, there's the axillary nerve, and you can see that it comes off posteriorly and then kind of wraps around anteriorly to innervate those muscles in the skin. So that's where you're going to find the axillary nerve. Okay, we also mentioned musculocutaneous nerve, and I don't know if we have a better picture anteriorly. Yeah, you'll see it better anteriorly. So here's musculocutaneous nerve, and you can see that it's coming off the brachial plexus, kind of coming posterior to the humerus, the head of the humerus, and then down, paralleling the humerus all the way down there. Median nerve is going to be medial to that. So if you're having trouble distinguishing between musculocutaneous, median, and ulnar, it kind of goes in that order from center and then medially. So the median nerve here is medial to musculocutaneous, and the ulnar nerve is going to be the most medial of all of them, right? Because it's got to go down towards the pinky side of the forearm. The radial nerve, of course, is going to be seen on the lateral aspect of the anterior arm because it's going to go towards the thumb side. But you can start to see radial nerve posteriorly as well. You can actually see it cross, coming out from underneath the scapula and crossing so that it can come over to the radial side of the arm. So you see that radial nerve, at least for the first half of the nerve, is largely posterior, as well as the axillary nerve. Those ones are going to be seen most easily on the posterior view. Anterior is where you're going to see those three that form musculocutaneous, median nerve, and ulnar nerve. And I would just learn them in that order. Musculocutaneous, median, and ulnar, going from kind of lateral to medial. And you see the median nerve comes all the way down, actually into the hand. So there are some models in the lab that we'll go through, and you can look at these nerves on the model, but as usual, I only have a couple of those models, and so I may also use some of these cadaver photos. So make sure that you can identify these nerves on a cadaver photo as well. Some of these are arteries, and so you don't need to learn the ones that are arteries. Like the really big one, that's like subclavian artery, and then you can see axillary artery here, So you can ignore the arteries, but just take a look at the nerve. So you can see musculocutaneous comes here off the brachial plexus. You can see the median nerve coming off the brachial plexus as well. And then let's see if we can find the ulnar nerve. There's the ulnar nerve. Very small compared to the median. And remember, it is medial to the median. So if you can identify the median, then you're going to see that the ulnar is even more medial to that. Notice the radial nerve is going to tuck under early and go posterior. So you're only going to see that for a very short while on the anterior view. Excuse me. And axillary, you're not even going to be able to see very well here because it's covered by the artery, and that axillary nerve goes posterior. So if you had a posterior view, you'd be able to see that more easily. Okay, so just wanted to briefly mention sensory innervation of the hand, because a lot of people have symptoms in this area, and so you can determine what nerve is the problem by which area of the hand is having trouble with sensation. So we talked about earlier that the median nerve does kind of the radial side of the hand anteriorly. So the yellow part is what is covered by the median nerve. It also covers the tips of the finger, both anterior and posterior. Notice here this delineation on the fourth digit. So the median nerve stops on that lateral aspect of the fourth digit, and that's where the ulnar nerve picks up sensation, both anterior and posterior. Posteriorly, the radial nerve will give you the area that's covered by the median nerve on the anterior side. And so by asking someone, where is your numbness, where is your pain, where are your pins and needles, you can determine exactly which nerve is being damaged or irritated. And so the median nerve goes through the carpal tunnel. And so carpal tunnel syndrome is usually either irritation or even damage to the median nerve. So people will have numbness, tingling of the thumb and the first two fingers. Usually does not involve the pinky. The pinky is going to be the ulnar nerve if you have trouble there. So here's the case of Sarah. She works as an administrative assistant at the college, and for the last 6 weeks she's noticed some tingling in her wrist and hand. She specifically notes kind of a pins and needles sensation on the palmar side of her right hand from the middle finger over to the thumb. And she's been waking up at night with pain and tingling. It started bothering her at work now when she's been typing for a long time. So based on her story of it being the palmar side or the anterior side of the hand from the middle finger over to the thumb, that should help you localize what nerve is involved there. And that's going to be, as I mentioned earlier, the median nerve, and she probably has a mild form of carpal tunnel syndrome. All right, let's go down to the lumbar plexus, and then we'll talk briefly about the sacral plexus. And I just want to mention 3 nerves here for you to learn the function of. Some of them we'll be able to see in the lab, and some of them will be a little bit difficult. The lateral femoral cutaneous nerve is going to give you mostly sensory information, and so that term cutaneous, that means skin. So that's going to be a clue to you that this nerve is largely sensory information, and it's going to give you information from anterior, lateral, and posterior thigh. The femoral nerve is going to give you both motor and sensation. So the motor is going to be to the quadriceps femoris, sartorius, pectineus, iliopsoas. Sensory is going to come from the anterior medial thigh and from the medial leg and foot. So that's a pretty large nerve that controls a lot of large muscles and covers a large area of sensation. The obturator nerve is going to give you motor and sensation as well. Motor will be to gracilis, obturator externus, and those adductor muscles like adductor magnus, for example, and the other adductor muscles. And then it will give you sensation from the medial thigh. If we move down to the sacral plexus, there's a few more nerves for you to learn here. Posterior femoral cutaneous nerve. So remember that term cutaneous again means skin, so you're only going to get sensory information. This is going to give you information from the perineum. Excuse me, that's the area like surrounding the anus and genitalia. So that a very sensitive area sends its information through the posterior femoral cutaneous nerve. And then it's also going to give you posterior thigh and leg. Sciatic nerve, which is super important. A lot of people have trouble there. It gives you both motor and some sensation. So the motor is going to be the semimembranosus, tendinosus, and adductor magnus. So some of those posterior leg muscles. And then it's going to split into the tibial and fibular nerves, which we'll talk about separate. And those are going to have both sensation and motor as well. The pudendal nerve, I just put in there because that's important gynecologically. Because it gives you sensory from the external genitalia, we have to deaden that often when we do procedures on women, for example. The gynecologist will try to deaden that nerve before doing any procedures around the external genitalia. We can also sometimes numb that before doing procedures during deliveries. It also gives some motor commands to some of the muscles around that area, including the external anal and urethral sphincters. So that's another important nerve. And again, we'll try to find these. Some of these will be visible on the models that we have. Okay, I mentioned that the sciatic nerve kind of split into the tibial and the fibular nerve. So tibial nerve is going to give motor, both motor and sensation. Motor is going to go to knee flexors and to ankle plantar flexors. So you can review those muscles if you can't remember offhand which ones those are. Sensory information will be from the posterior leg and the plantar surface of the foot. Fibular nerve will give you motor to biceps femoris, fibularis longus and brevis, tibialis anterior, and some toe extensors, and sensory information from the anterior leg and the lateral foot. So people who have trouble with a sciatic nerve, often their pain, if they're experiencing it, will be more in the thigh, like the lateral aspect of the thigh. But it can go all the way down to the leg, to the lower leg, because these nerves here carry sensory information from those areas as well. All right, so we will try and find these together in the lab. So sciatic nerve you see comes posterior. You can't see it very well in the anterior view there. Posteriorly, look how large it is. It is the largest nerve in the body as far as the thickness of it, because it carries basically all of the information to and from the lower leg. So it's a very important nerve to remember, and you can see that it's going to split into tibial and fibular nerves, which then have their own branches. Pudendal nerve you can also see coming off posteriorly. Posterior femoral cutaneous is also coming off posteriorly. Lateral femoral cutaneous you see coming off here. Femoral nerve you see coming off here anteriorly. And we should be able to see most of those on the models in the lab. So here are some more pictures, and these are in the lab as well. Make sure you can identify these major nerves. You're going to see sciatic nerve is going to be this big bundle. So if you see a fat bundle of nerves on the posterior aspect of the upper thigh or the buttocks, that's going to be sciatic nerve. So that should be an easy one for you to identify. I think that's the main one really on that posterior view. Oh, pudendal nerve is in there as well. That's going to be the one that's most medial. And then here on this view, which is also in the lab, you can see tibial nerve coming down here. It kind of follows along with a popliteal artery. Let's see if we can see, I guess you can't see fibular. Oh, there it is, common fibulars on this over here. So the sciatic kind of comes up here and it splits into tibial and fibular there. So make sure you can identify those on these cadaver photos as well.